Welcome. We had started a discussion, but and those of you watching can see on the screen on the replay, we're discussing a patient. We know nothing about the patient. We have a sodium of 126 with a potassium of 7.6, a chloride of 98 with a bicarb of 21, a BUN of 30 with a creatinine of 1.3, and we're told that this is up from previous creatinine 3 months ago. There was 1.1, and the glucose is 127, and the patient has a normal albumin. And so the first thing, and I think Kevin, your instinct is right. You always look at what the danger is. So this is if you rotate with Travis in the emergency department, what makes you start sweating? And potassium is 7.6. So Norma, let's say you're in the emergency department and you see the potassium is 7.6. What are you going to do? So as opposed to sitting around trying to figure out the diagnosis, did we lose Norma? I think we lost. Here, Norma's getting back on, right? Are you back on, Norma? Hello, Norma, unmute yourself.
Oh, sorry about that.
Great. So we have a potassium of 7.6. You're in the emergency department. Travis looks at you and says, what should we do?
Okay, so, well, the first thing that we could do is we can start with giving this patient potassium binder. We can give them, they could be dehydrated. We can give them some normal saline. We could give them calcium. We could give them insulin, glucose, essentially
okay, so
barrage them with stuff.
So you've now memorized the entire list. Now we have to prioritize the list. And that's one of the problems that we have as we're learning medicine, is to try to figure out how to prioritize something. And I would argue that the only thing on here that's going to kill the patient quickly is the high potassium. Now, somebody suggested, Shioma suggested an EKG. Will the EKG change our approach to a potassium of 7.6?
No.
No, we ought to get it, but we need to decide what is the most important thing we can do to stabilize the heart and decrease the risk of bad arrhythmia. And they can have an absolutely normal looking EKG with a potassium of 7.6. You wouldn't expect it. You wouldn't expect it, but the degree of abnormality of that EKG won't change what you're going to do. So which one of those things is going to work the fastest?
The calcium.
You're 100% correct. So that's where we go. That's where we go first. So Travis, you do this for a living in the ER. Tell them how you teach about this in the emergency department.
So I think prioritizing the order of medications, I think, is the first thing. So one, if they are a dialysis patient, I mean, your emergent treatment is right there. But until you can get the dialysis nurse to come and dialyze them, there's some temporizing measures you can do. One of them being giving calcium gluconate, 2 grams. If they have a central line, you can use calcium chloride. But that's the first thing I probably would go to. And I would give that calcium until their EKG normalizes, if they have EKG findings. Then I would also give albuterol nebs, 20 milligrams. You can give it over an hour. And then probably at the same time, I would also give them insulin and glucose. Usually it's about 10 units of insulin and, maybe like a 25 grams or just like an amp of D50 you can give that and make sure that you're doing like, Q 30-minute AccuChecks on patients who are non-diabetics.
So let's go over each of those, because I think that that's understanding the priority. So notice that potassium binders are not on that list. We're going to figure out why the patient has high potassium and figure out if we need to give potassium binders after a while. But Kevin, why are we giving the calcium gluconate first?
I don't know the technical reason, but I know the calcium gluconate will stabilize the cardiac membrane, and so
Right,
therefore
and-
you're less likely to have them go into an arrhythmia.
And the Curious Clinicians had an entire episode on that, which even after I listened to it, I didn't totally understand it. But Mario says that has something to do with the voltage sodium channels. The electrophysiology of this always gets me confused. But the most important thing is to know that that's the first thing to do. And I think you do that regardless of the EKG. But I think Travis's idea that if the EKG is abnormal, that you would continue treating to get rid of the abnormalities. Now, do you know how to remember the order of abnormality with hyperkalemia? Has anybody taught you this, Kevin? Apparently not.
Sorry. Initially, you get the peak T waves, and then you'll have the P wave depressions.
Okay, so Norma says she has a memory device, and we may have discussed this at unRemarkable Labs once before, but I was taught this by a resident once, which is a beautiful thing. So let's see what Norma says.
Well, now that I'm on the spot, I might forget it. But I remember it as PQRST. So P for peak T waves, QRS for prolonged QRS interval, and then I have then my T waves then start to get flat, and then I get my sine wave. That's how I kind of remember that.
Okay, so here's a cool way to remember it. Think of fly fishing. So you cast your rod and you catch the T wave, and you start reeling in the T wave. So the T wave goes up, and then you start to prolong the QT interval and the PR interval, and then you eventually stretch out the QRS and get the sine wave. And so the order of things is just the way it would be if you were pulling up on the T wave. Does that make sense to people? Nope.
Yes.
And I'm jumping ahead a little bit. Since we're talking so much about the EKG, I actually just screenshotted the patient's EKG on admission and put it in the chat without any identifying information. So you guys feel free to take a look.
Can you guys see it on my screen or no?
I just pulled it up myself. Did anybody else pull it up? I think you would suspect hyperkalemia if this is all you had. If you did the EKG first. Right? It didn't show up. There's some peak T waves, but that's about all I saw.
Same.
Okay, so what happened to our template?
Can you see it?
I have now I see the original template, but I don't see what we'd already written down.
There we go.
Okay, great. Okay, so we're going to treat the potassium, but now we're going to go back to diagnostics. So we're going to have to figure out why the patient has a high potassium. What else do we have to figure out? why they have a low sodium. The bicarb is a little low. We're not going to get too excited about this right now. This patient does not have end-stage renal disease. What do you think about the BUN and creatinine? Kevin, did you pay any attention to the BUN and creatinine?
Yeah, I did. The ratio, it's kind of, I don't, I'm not good at math all the time, but it's pretty high. It's up around 30.
Yeah, it's probably 25, but certainly higher than we would expect. So now we have to think about who this patient is, and we still don't know who the patient is. We don't know what the volume status is. So the way I think about hyponatremia is I think about volume status. And is this a volume contracted patient? Is this an edematous patient? Or is this a euvolemic patient? I doubt that it's euvolemic with this BUN and creatinine, and it could be an edematous patient. Now, but we have to put that together with the hyperkalemia, and everybody's getting excited about the hyperkalemia. So what kind of aldosterone disorder gives us elevated potassium? Norma, do you know what kind of aldosterone disorder causes elevated potassium?
Well, I'm not sure if I'm gonna answer this correctly, but I know that type 4 renal tubular acidosis can cause a hyperaldosterone state, and if this patient is on, or if this patient is diabetic, that's an aldosterone essentially insensitive state. So could be one of those.
Okay.
Could be a couple of those things.
So let's go over that, because I want to sit down and make sure that everybody really understands this. So did you say hypo or hyperaldosterone state?
Hyper, sorry.
So now you have an opportunity to learn, because that's exactly incorrect. By the way, you just got feedback. Okay, so now you're about to learn something, which is good. So decreased aldo gives you hyperkalemia. Let's think about that so that it's easy to remember. What happens in diabetic nephropathy is that you get Kimmel-Steele-Wilson lesions, and they preferentially in many patients affect the juxtaglomerular apparatus. Why is that important? That's where renin is made. So the classic type 4 RTA is hyporenin, hypoaldo. So they have both low renin and low aldo. If you have low aldo, then you're going to hold on to potassium preferentially over sodium. So you're going to have a low urinary potassium in the face of an elevated serum potassium with a higher urine sodium. Now, this is classic for diabetic nephropathy. It also happens in sickle cell nephropathy sometimes, and lupus nephropathy. And then we have a series of drugs that will give us hypoaldo. So what are the drugs that give us hypoaldo?
Spironolactone.
So the classic one, so if we're concerned about the renin, angiotensin 1, angiotensin 2, aldosterone, the RAS system, anything that blocks the RAS system can lead to relative hypoaldosteronism. So therefore, ACE inhibitors, ARBs, and aldo antagonists, so spironolactone, eplerenone, ACEs and ARBs will all do it. Then we have more unusual things that are showing up in the chat, And so we'll have to see what other medications the person's on. It does not look like the patient has a glucose of 127, which probably makes diabetes less likely. Why else would you have low aldo? Well, where's aldo made?
In the adrenal glands.
In the adrenal glands. So if we lose our adrenal glands, we can get both Addison's, so we can get both glucocorticoid and mineralocorticoid deficiency, right? And so routine Addison's, you usually don't get hyperkalemia unless the entire adrenal gland is compromised. So that usually happens either with cancer going to the adrenal glands or tuberculosis or something like that. But that has to be in our differential here. And this is without knowing anything about the blood pressure, etc. Now, the other thing that's going on is we're suspicious for volume contraction because the BUN is elevated over the creatinine, and the creatinine's up a little bit. So urinalysis might help us a little bit. Volume contraction usually would not give you that severe hyperkalemia by itself without one of these other things. Somebody mentioned trimethoprim sulfa, also known as Bactrim. That's usually just in really high doses. So that's mostly been described in people who with HIV who are being treated for PJP. And the reason is, so trimethoprim acts like a miloride. So the other drugs we'd have to worry about are miloride and triamterene, which are potassium sparing drugs. And trimethoprim acts like a miloride. So with very high doses of trimethoprim sulfa, you can get hyperkalemia. That's going to be much more likely in little kids because of the dose relationship with their body weight. But occasionally you'll see that in adults. So I think it's time for us to learn more about this patient so that we can work our way through. In the meantime, I'm ordering urine electrolytes. I'm not real concerned about that bicarb of 21. I'm just not going to do anything about it right now. That may be secondary to the hyperkalemia, but the hyperkalemia is where all the action is. I'm not worried about the sodium of 126, but I want to try to figure out whether this is pure volume contraction or not, and whether that'll get better just with volume. I'm not worried about treating it too fast. At 126, I don't think we're at any risk for pontine demyelination. Okay, so Sal, tell us who this guy is.
Yeah, so great discussion, and you guys are right on track thinking as we did. So this patient is 59 years old. He has a medical history. He actually is just chilling. He is coming in from clinic because he was told that his labs were abnormal. You ask a detailed review of systems, and he denies localizing symptoms with the exception that his mouth is a little bit dry. He might be a little bit dehydrated. For his past medical history, he has left-sided RCC, renal cell carcinoma, with diffuse metastasis. And those mets are to, poor guy, lung, mediastinum, and adrenal glands. Most recently, he has been treated with nivolumab, one of the new checkpoint inhibitors, like the immune therapies. And that has been stopped about 6 months prior to this. due to concern for hypophysitis. And specifically, there are some decreased thyroid function tests, and there was some concern. So that medicine is stopped.
So let's just talk about checkpoint inhibitors. They scare the hell out of me. And immediately, if the patient's been on a checkpoint inhibitor, I look up checkpoint inhibitors, that particular one, and see what the renal side effects are, and what the other side effects are, because they have incredible number of side effects. So Sal, if we go to the book, what do we learn about nivolumab? I guess so it can affect the pituitary.
Absolutely, it can affect the pituitary. I think that the common teaching is that the checkpoint inhibitors can lead to an itis of any organ. Koshal's all over it. To be honest, I don't know like the primary literature, so I just, it's always on my differential that a side effect of an immune checkpoint inhibitor is an itis or inflammation of any organ, but organs that I've specifically heard of is specifically the pituitary and the lungs are what I most commonly have seen. I don't know if anybody else wants to chime in on things they've seen on the warts.
And certainly, does the pituitary go away when you stop it quickly or not? And I think it also causes some renal side effects, and Travis says cardiac side effects. Anybody looks it up and wants to put in the chat, that would help everyone. Checkpoint inhibitors. Click to download. As usual, AMK comes through. Skin rash. Pituitary is not uncommon. Diarrhea is not uncommon. Elevated liver enzymes, pneumonitis, thyroid. Okay, so I guess the question is this more likely to be the adrenal metastases, or is this more likely to be the pituitary? And the pituitary usually doesn't cause hyperkalemia. And so we can't just blame all of this on pituitary malfunction, because aldo should be independent of that, as best I know. So I'm much more interested in considering the possibility that these metastases to the adrenal gland are really what's causing it. So how are we going to work that up? So that's the job for Kevin and Norma, is to think about what tests you want to get. So this is part and parcel of internship and residency, is knowing what test to order. Adrenal involvement has jumped to the top of our list. And with adrenal involvement, what tests are we going to get to convince us that that's the problem?
I might be wrong, but I was thinking maybe like do like an ACTH stimulation test, something along those lines, to check adrenal function to make sure that it has an appropriate response.
For me, that would be step 2. I agree with that. What I like to do is, this patient's coming in under stress, and get a random cortisol right now. And then I'm going to treat the patient as if the patient has Addison's symptoms. And how am I going to do that and not mess up the cortisone stim test for the next day? This is really useful information. So so you will never go wrong as an intern or resident in giving someone the appropriate steroid and getting a random cortisol and then sorting it out the next morning. if you give them the right glucocorticoid. And Travis and Kishal have heard me say this before, so, or either that or they're very smart. So dexamethasone does not interfere with the measurement of cortisol. It's the only glucocorticoid that we give that does not. So what I would do is, and someone suggests repeat the BMP. I believe the BMP because I saw the EKG and it did have peak T waves. I'm going to give a stress dose of dexamethasone for the patient's safety. Get a random cortisol. If it's low, the next morning I'll do that cortisol stimulation test, and that's going to actually be really important now, because we know the patient had a pituitary problem in the past. And so if there's low cortisol, we don't know whether this is a pituitary problem or whether or not it's a primary adrenal problem. So then there's a discussion in the chat about whether we should check renin and aldo here. I like just getting a urine sodium and urine potassium. If the urine potassium is low and the urine sodium is high, which would not be a surprise to me if that's what it was, then I could deduce that the patient is not making aldo, because the patient should be making aldo with a potassium of 7.5 and 7.6 and trying to get that. So a low potassium and a high urine sodium, to me physiologically would be hypoaldo in this situation. And so then I'd have to think about giving this patient a synthetic aldo in the future if this patient has both glucocorticoid and mineralocorticoid deficiency. So that's what I would do. Other people might do it in a different way. So Sal, tell us what you actually did.
Yeah, absolutely. So admission was a little bit challenging. Towards the beginning of the admission, there was concern for adrenal insufficiency. And for treatment for adrenal insufficiency, hydrocortisone was used. So the random cortisol that was ordered was after the hydrocortisone was given, unfortunately.
Okay, so that's a great example of a mistake that we're all learning from today. And so that is a great teaching point that most medical students and interns haven't been taught to think through. And that's okay, because I don't think that I knew this until about 10, 15 years ago, and I've been around a long time. It is a fine point of how you take care of people. So if you've gotten hydrocortisone, then that sort of screws up everything we're going to do to try to prove whether or not the patient has adrenal insufficiency. Okay, did we get a urine sodium potassium?
We did not. The patient, because he was feeling fine, this is also a part of real life, was very insistent on going home. This was actually right around Christmas Eve, and the patient was trying to find a way to get home to see his family, another reality that we'll face in the hospital. But what I can do is kind of give a little bit more history and background, and talk about the empiric treatment that we did, Dr. Centaur, if that's helpful.
Great.
And then
Please
and
teach
then the
us.
diagnosis. Yeah. So I left a little bit out in terms of his medical history and medications. He was also on prednisone, and notably, he was switched from hydrocortisone to prednisone a few weeks prior to this. So, and as a lot of you might know, that hydrocortisone has mineralocorticoid effect, whereas prednisone typically has glucocorticoid effect. So if you switch from a mineralocorticoid like hydrocortisone to a glucocorticoid like prednisone, you can precipitate exactly a mineralocorticoid adrenal type insufficiency, which could lead to some of the electrolyte derangement seen, the hyperkalemia, the hyponatremia, the non-GAP metabolic acidosis, and potentially even a type 4 RTA, as you've mentioned. There are a couple of other things in this patient. This patient in particular took a lot of supplements that I didn't mention, and these supplements were high in potassium. So there's a chance that the supplements leading in high in potassium, coupled with a mineralocorticoid deficiency, could have led to the hyperkalemia and the hyponatremia and the non-GAP acidosis. So I learned a lot from this case. The attending at the time had a pretty high index of suspicion for like precipitated mineralocorticoid deficiency, first caused by the RCC mets to the adrenal glands and then exacerbated by withdrawal of the hydrocortisone. He said, I'll see him in clinic next week, it's fine. Let's just go ahead and empirically start some mineralocorticoid and I'll check labs in a week to see how he does. And in like 1 to 2 weeks on repeat, after he had been switched to like some fludrocortisone, which is a mineralocorticoid, his sodium and potassium had normalized.
So there are a couple of interesting things here. Then let me just expand on that. Some patients will not have a good response to prednisone because prednisone is a prodrug. And so some people with liver disease can't metabolize prednisone to prednisolone because prednisolone is the active drug and prednisone is a prodrug. So if prednisone is not working for your patient and you're pretty sure you have the right diagnosis, occasionally people don't metabolize prednisone well, and so you may need to go to prednisolone. It's important to know how to give fludrocortisone. So 9-alpha fludrocortisone, which goes by the trade name Florinef, is the way we give artificial mineralocorticoid. It's a low dose, can cause hypertension, but that's what you would do if you really needed to control. If you felt that the patient was totally aldo deficient because of involvement of either taking out the adrenals or because of the metastases to the adrenals. Mario asked a good question. Is that why we use prednisolone for alcoholic hepatitis? That is exactly why we use prednisolone. That's a great understanding of what I said, Mario, and I really like you. I really like that you thought through that like that. Whenever you're treating liver disease, they always use prednisolone. The reason we don't use prednisolone is it's much more expensive than prednisone because it's much more expensive to produce. So for most patients, prednisone is just fine. What I was not familiar with hydrocortisone also having significant so it's not really a mineralocorticoid, it's a glucocorticoid and mineralocorticoid. So let's make sure everybody understands that. The hydrocortisone has both mineralocorticoid and glucocorticoid properties, although some patients still need fludrocortisone in addition to hydrocortisone. You can give prednisolone IV or PO, Norma. It's methylprednisolone when you give it IV. I think that's Solumedrol. Is that right? Somebody correct me if I'm wrong. Is Solumedrol methylprednisolone?
I didn't know
Yes,
they
I'm
were.
pretty sure.
Are they okay? I didn't know that they were the same thing. Same thing, different name.
Did I have that right? Sal, you're pretty smart. Somebody look it up.
I looked it
That's
up. It's
right.
methylprednisolone.
It's
Yeah,
methylprednisolone.
methylprednisolone is Solumedrol. That's maybe one of the reasons we use Solumedrol. Okay, let's think about what the big teaching points. So Norma and Kevin were extraordinarily brave to attack this case. Ladies first. Norma, give us the two most important things that you're going to take from this presentation?
So the first thing that I'm going to take from this is that that pearl of dexamethasone not affecting cortisol levels. I did not know that. And it is definitely something that I will take with me for the foreseeable future. And just an overall, I guess, learning exercise is to try to see the forest for the trees. I focused immediately on that high potassium, and I didn't really consider anything else, because I'm in that mindset of that potassium might kill somebody. You're going to have to lower that and then kind of figure out. But it was good to kind of step back and get a good sense of why the patient is actually here and what's actually going on.
So the instinct to worry about the potassium first is a great instinct. Once you're starting to get the potassium down, then you have to go back and look at everything and say, okay, what's the differential, the variety of differential diagnosis, and start trying to figure out what's going on with these other labs also, and then going back and finding out all the stuff that Sal hid from us. As every good chief resident does, they always hide something from me. Kevin, what are your big learning points?
Well, I was also gonna take the point about the dexamethasone, but I'll pick a different two. The first one is just the checkpoint inhibitors. I know they have like a whole slew of side effects, but definitely the fact that they cause an itis of pretty much any organ wasn't really something that I had ever considered before. And then the other point, which was one you actually just kind of mentioned, was the prednisolone in liver disease, something that I never really thought about. Of course, it's intuitive when you think about it, but sometimes, like Norma said, you can't see the forest through the trees. So until somebody points it out, some of those things don't make a whole lot of sense until it does.
So Natasha, you are our wonderful scribe. What are the big teaching points that you're going to take away? And you're going to have interns in 2 days, and so these are things that you might want to teach your brand new interns.
Yeah, I think the biggest step from med school to residency is not just having the knowledge, but applying it. So definitely if you see an abnormal potassium, especially one greater than 7, the first step is to give calcium gluconate, stabilize, and then you can give insulin and albuterol obviously as well. And the endpoint being once the EKG normalizes. And then I also did not, I had one night at the VA on night float where I had 2 different patients come in with checkpoint inhibitors, toxicity. One had pneumonitis and one had encephalitis. It was really interesting. So I was relatively familiar with those, but also the giving Dex when you haven't gotten a cortisol. I learned that on MICU last month, and that was really helpful. I think that's very useful to know.
Great. And Sal, you were the presenter. So what are the two biggest things in our discussion that you will use? Because Sal is taking over for me. I go on service tomorrow, and then next Thursday I hand off to Sal, and he's going to be a ward attending for the first time next Thursday.
Get excited. Get nervous, more like. But thank you, Natasha. So things that I learned in this case are, number one, thinking about the different, for each medicine, such as hydrocortisone, prednisone, fludrocortisone, the spectrum of mineralocorticoid and glucocorticoid effects. That's not something that I was deliberate in thinking about. And I'm definitely take that with me. And the other thing is just, I mean, this isn't totally medical, but we often are in situations where we have to work with patients and pursue shared decision making. So I think this was a really nice example led by my attending of shared decision making, allowing this patient who had metastatic cancer to spend Christmas with his family, whereas that's might have not always been the case, depending on the team.
Great.
So.
Well, thanks everyone for joining us. We're going to an every 2-week schedule, and every third session is going to be hosted by WashU and the great Mohit Harsh. And so in 2 weeks, it's going to be a renal case and totally presented by the people at WashU. And then in 4 weeks from now, we're going to have a very, very interesting case that this is pure nepotism. My daughter is going to present to us. My daughter's a dietitian with a master's in nutrition, and she's going to present a 2-year-old who's an extremely picky eater, and we're going to discuss working up potential nutritional deficiencies, first in little kids, then we'll talk about adolescents, and then we'll talk about adults. So that should be a lot of fun. That'll be, I think, on July 20th. And we're gonna make sure we have a couple of our med-peds residents to be the discussants, because they know a lot more about 2-year-olds. And Keith wants to know if I get an extra diet. So I have a 5 Coke to Diet Coke bet with one of my golf buddies who went to Mississippi State. He actually played football there. And so if Virginia wins this game, they're ahead 4-0 in the 6th, and they're throwing a no-hitter. And Kevin wants to know whether I get an extra Diet Coke if they no-hit. I will definitely ask for that, Kevin. Thank you so much. Y'all have a wonderful evening.
Thanks, everybody.